So thank you for being with us today. And do let me hand the session over to Dr. Didyk. Thank you, Nicole. Oh, we're not hearing. Well, I'm not hearing you, Nicole. So
chat's unmuted.
There, now we've got you.
Okay.
Now we've got you. Okay.
I was just going to thank everyone for the invitation, as well as for the patience with my technical issues that I seem to be having. I'm in Nova Scotia today. I'm actually on a vacation, which I'm very thankful for. But thanks so much for bearing with me in this with this talk. So I'm going to rely on Pete to share my slides. And we're going to talk about alcohol and the aging brain, and focus a little bit on why should we even have a discussion about alcohol when we're talking about aging and when we're talking about brain health. Next, please. So the objectives for today are to do a review of alcohol use in older adults. So, we might think that people tend to not drink as they get older, or maybe drink more. So we'll talk about that. We'll talk about the effects of alcohol on the aging brain, and also some of the negative effects that can happen. And we will touch on a little bit about alcohol use and the guidelines for that and how to reduce alcohol use. But most of that, one of my colleagues, couple of my colleagues are going to spend more time on. So on the next slide, I would invite you to meet Louis. He's 78. He is a patient who's come in to me to see me as a specialist in geriatric medicine because he's having falls. He's fallen a couple of times over the last year, which isn't normal. Falling isn't a normal part of aging. Louis worked as an executive, and he was the head of sales. So he did a lot of traveling and a lot of socializing and a lot of drinking in his working life. And some of that has continued. What he describes is that he just feels off balance, and especially if there's uneven ground or something that would challenge his balance. He also feels like his memory is a little bit off, and he's more anxious than he used to be. He retired about 10 years ago. So we do a comprehensive assessment, and we do talk about alcohol use. It turns out that he has a couple of beers at lunch, usually, or maybe one after lunch, one after dinner. He does have 2 glasses of wine at dinner. And then if he's out socially, he might have another drink. So on the next slide, we can, what kind of is running through my mind when I hear that alcohol history, as well as looking at other things, is I wonder if I should have a talk about alcohol consumption, how much is too much, and if he should quit or cut down, and what harm could alcohol be doing in Louis's life. So on the next slide, let's talk about alcohol use in older adults. So almost half of older adults do drink alcohol. So it's not like people stop drinking or tend to drink less necessarily. And a good percentage of people, so 14.5%, do drink more than recommended, or they may have episodes of binge drinking. And almost 1 in 5 would have a drink of alcohol every day. Let's look at the next slide. Why is alcohol consumption different in older adults? Well, it's, aging, even normal aging, people are more likely to have medical conditions that can be a normal part of aging or just more common with aging, and also more likely to be on medications. So if we take that into consideration, not just age, then 37% of people might be consuming alcohol in a way that's harmful. So it might be that the drinking is the problem. And 53% their drinking might contribute to some hazardous behavior or hazardous situations. So they might be more likely to interact with medications or medical conditions, or the person's alcohol use might encourage them to participate in other risky behaviors. So on the next slide, and I know this is going to be covered later, but what is a drink? So again, sometimes people will say they drink socially or they just drink a glass of wine a day. And sometimes people, will say, oh, I just have a little drink like this, or it's a big tumbler full of wine. So knowing how much is in a drink is very important. Next slide. And we always used to say that, for most of my practice, we would say that people should drink, men can have up to 2 drinks a day. And over a week, they shouldn't have more than 15. And it's important to not have too many drinks at one sitting. And same thing for women, but women, mostly, I guess, because of smaller body size, would have even less drinks than that. But the latest guidelines are that, and I know, again, this will be covered in more detail, are that probably there is no medical reason to drink alcohol. And so if you don't want to drink alcohol, that's okay. And the evidence has gone back and forth about, is red wine good for us, or does alcohol have some benefits? And it can certainly help with some symptoms of some medical conditions. But overall, medically, there's no reason. So you'll probably be interested to find out a little bit later what's actually recommended and to maybe reflect a little bit about where you are in those guidelines. So on the next slide, why should we think about the amount that we drink, and why would you want to drink less? So alcohol, for sure, is, as I mentioned, there's no real medical reason to consume alcohol or to put that into your system. And it can definitely have toxic effects. And we see this all the time in practice. And think about Louis again, and whether or not his alcohol could be getting in his way. Alcohol toxicity, when I think about it, I think about short-term toxicity and longer-term toxicity. The long-term effects are definitely something that we see. And people are sometimes surprised when they find out that alcohol has been a contributor to some of the conditions they're living with. So over the long term, alcohol can cause damage to peripheral nerves. So those are mostly the nerves in the feet, right? They're very peripheral. They're sort of at the extremities of our bodies. And alcohol can actually cause some dying back of those nerves. And that can make a person less likely to kind of know where their feet are in space when they're walking around. So people tend to walk with a wider base of support and just be more tentative when they are walking. And that can be alcohol related. Alcohol can cause shrinkage of the cerebellum. So that's kind of the back part, the kind of cauliflower part on the brain, if you see pictures of the brain. But the cerebellum is really important in balance. And so with enough alcohol, and that can even happen in the short term, that's why the part of the sobriety test can be doing a balance test, right? Walking heel to toe, because alcohol is toxic to the cerebellum in the short term, but also the longer term. So people who've had a long history of heavy drinking can have shrinkage in that cerebellum, and it can affect their movement. Alcohol is a risk factor. Alcohol use is a risk factor for the development of dementia. And there's even an entity called an alcohol-related dementia. So a lot of the symptoms of alcohol-related dementia overlap with frontotemporal dementia, actually. So there are a lot of changes in a person's behavior with alcohol-related dementia. And it's usually not it doesn't usually respond to the Alzheimer medications the way that an Alzheimer's dementia would be. Alcohol is a downer, so it can worsen depression. And sometimes we think of people treating their depression with alcohol or so-called self-medicating, but it can cause depression or worsen depression. It might help in the short term with anxiety, but over the long term, it doesn't help. Alcohol use can cause seizures. Or its withdrawal can also cause seizures. So sometimes if people don't have access to alcohol, or they decide to quit cold turkey, that's a common side effect of that in people who are drinking very heavily is seizure. Alcohol affects sleep quality. So we might think that taking a shot before bed helps us sleep, and it might help you feel like you fall asleep. But just like sleeping pills, if we look at your actual sleep architecture, if we stuck an EEG on the brain while someone's sleeping after having drinks, the architecture would be all messed up and you'd be less likely to go into that restorative REM sleep. So it really doesn't help. And you can ask my mom if drinking alcohol causes gout flares. And she doesn't drink heavily, but she definitely is very careful about drinking because she's petrified of causing a flare of gout. And that's kind of a classic scenario that we learned about in medical school, is that Pickwickian syndrome, where people are, overeating and drinking alcohol or beer as a type of alcohol and getting a gout flare. So those are kind of all of the things that can happen when a person drinks alcohol, short-term and long-term. And let's look at the next slide. And then just to add a little bit more information to that and kind of bashing drinking, I guess, or at least making us think about, how we want to balance alcohol use with our other health issues. Alcohol does increase the risk of dementia. So those who've drank alcohol heavily throughout life are more likely to develop dementia. And I'm going to show you later how, if we look at what are the lifestyle changes that we can do to reduce our risk of dementia as a population, cutting down on alcohol is definitely one of those strategies. Alcohol can interfere with medications. So I'm going to talk about that in a bit more detail. But, and even many of us are probably taking medications where it says right on the bottle that alcohol, there's a clap of thunder here in the Maritimes. I don't know if you heard that, but alcohol can make us drowsier. If we're on a medication that already makes us drowsy, alcohol can exacerbate that. And it increases the risk of falls through multiple mechanisms. So it can affect those peripheral nerves. It can affect that cerebellum. It can cause a person to be more depressed or less attentive. So for sure, if someone comes in to see me about falling, we're going to have a talk about alcohol. Older adults are less likely perhaps to drink to excess, but more likely to be affected by their alcohol use. So they're more likely to be admitted to hospital with an alcohol-related illness. So that could be a seizure or a fall or something else, or a medication interaction. And I was interested and kind of surprised to find out that the highest alcohol-related death rate is for sort of the middle-aged to younger old. And there could be multiple reasons for that, but it definitely makes me think that those of us in that age group, should be more cautious. Let's look at the next slide, where we talk a little bit about alcohol and dementia again. So alcohol use at moderate levels is associated with atrophy of the hippocampus. So we talked about the cerebellum, which is kind of that back part of the brain there, but the hippocampus is kind of that curly little shrimpy thing there. I think of it as a shrimp, and it's labeled there, which I hope you can read on your screen. But that hippocampus is very important in the formation of short-term memory. And alcohol use, those who've had moderate alcohol use or even light alcohol use apparently will have less bulk in that hippocampus. So there'll be shrinkage or atrophy. And I don't know if you've heard about the Lancet Commission, but in 2020, it was sort of a large expert panel that was looking at how to prevent dementia and looking at it from a global perspective. And they did put out a paper, which I sort of have it in the box there if you want to look it up. What are the interventions that can reduce the incidence of dementia? And they mentioned that limiting alcohol use is a strategy to reduce one's risk of dementia. And they indicate that 21 units or more weekly increases that dementia risk. But again, even light use does seem to cause some changes in the brain that might predispose to dementia. So, knowing that, I don't, again, I think it's important for us to sort of balance our choices about alcohol and maybe our other risk factors for dementia. And maybe reducing alcohol use is one way to reduce that risk personally. Let's talk about medications also, because 20 to 40% of older people who drink alcohol are also on medications that could have interactions. So, that might not be the first thing that we think about when we get a prescription, but definitely it can be very important and very hazardous if we don't pay attention to that. Let's look at the next slide for a little diagram about how alcohol affects other parts of the body. So we think about it affecting our brain, maybe our stomach, causing a gastritis, perhaps if we've overindulged. But what else what are some of the other things that alcohol can affect? Or that are also changes that can happen naturally in aging that can affect alcohol metabolism and how they would interact with meds. So just looking at the stomach, we metabolize alcohol less in the stomach as we get older. We have lower levels of alcohol dehydrogenase enzyme in our stomach, so less alcohol will be metabolized there. So more of it will get into the other systems. Older adults tend to have less muscle mass, more fat. Not saying older adults are naturally fat, necessarily have a higher body mass index, but for sure, just naturally, there's less muscle mass, and so alcohol is more likely to have a higher blood level in an older adult. And alcohol competes with medications in an enzyme system called cytochrome P450. So a lot of medications that we take, and some of them are listed there, like warfarin, a benzodiazepine like diazepam or lorazepam or any of the PAMs, or propranolol, which is a beta blocker. That is metabolized by the cytochrome P450 system also. And so if alcohol is competing with that, you might end up with higher levels of those medications in the blood. So if you don't adjust your dose for your alcohol consumption, you could end up with some pretty major side effects. On the next slide, there's a little chart showing how alcohol can interact with certain medications. And some of these may not be that common, but if we look, for example, like ranitidine or cimetidine, those are antacids. Like I think Pepcid is the name for ranitidine. So that can have a higher blood alcohol level if you're taking that medication. You could have lower medications of your phenytoin, or if you're taking medication for HIV, the high activity antiretrovirals, HAART, then that could end up with lower levels in your blood if you're drinking alcohol. Opioids, morphine and their derivatives could be higher levels. It could produce toxic metabolites like acetaminophen, right? That's Tylenol. So you might not really think about taking a Tylenol if you're having a drink, but it can have an effect. Certainly there can be more sedation. I see a question about sertraline. And that's an SSRI or an antidepressant. So as far as I know, there isn't a metabolic interaction. So as far as I know, they don't compete with the same enzymes or the same cytochrome P450 system. However, the side effects of sertraline, so if there is sedation related to sertraline, for example, then that could be worse if it's mixed with alcohol. So that's a good question. And, I think that a person should probably be cautious about alcohol use if they're taking any kind of a psychiatric medication, because they're both acting on the brain. Similarly with something like risperidone, right? So that's an antipsychotic. And again, that's also, it's kind of given as a tranquilizer, right? Some people would put that in the class of major tranquilizers. So taking alcohol with risperidone or olanzapine or quetiapine, any of those atypical antipsychotics, alcohol is going to exacerbate the sedation, that's associated with that medication, and increase the risk of sedation, falls, and probably confusion as well. So really, alcohol does not mix with those medications in any way. So let's go on to the next slide. And this is just a study where they looked at alcohol interactions in older adults and their medications. And they had this criteria, they shortened it to post-amino, which is potentially serious alcohol medication interactions in older adults. And they found that about 1 in 5, 19% had a higher fall risk in a medication. They were taking a medication that acted on their central nervous system. So like those examples of sertraline and risperidone and benzodiazepines. So 1 in 5 were living with that. And there actually was an 8% increase in injurious falls. Now that was after 4 years of the study, but still, falls are very serious. They can be very life-changing for an older adult. They did find that in heavy alcohol use, there was more likely to be an interaction. On the next slide, this is kind of the conclusions that the authors drew from their study. So they said that if you're a heavy drinker with those medications, it will increase your risk of falls. So antihypertensives, benzodiazepines, antipsychotics, antidepressants, antiepileptics, and even insulin. So if you drink heavily, and again, our definition of heavily may have shifted recently, but those will increase your risk for falls. Or if you take any alcohol while taking mirtazapine, which is an atypical antidepressant that also causes sedation, metronidazole, which is also called Flagyl, that's an antibiotic, or tricyclic antidepressants like amitriptyline, nortriptyline, Elavil is one of those class of medications. No, any alcohol use with that will increase fall risk. Now, just a word on falls on the next slide. Falls are serious. They are the cause of about 50% of injury-related deaths in older adults and 80% of injury-related hospitalizations in people over 65. And we definitely see that every day in the hospital. The cost to our community and our system is enormous. Almost, 5.6 billion as of 2018 is the cost for falls in older adults. So anything we can do to prevent falls is, in my books, is really good. Next slide, more serious news about falls. 90% of all hip fractures are associated with falls. And after a hip fracture, it's not often as simple as getting fixed up and going on your way. 25% of people will pass away within 6 months. And 50% rather, will go to live in long-term care if they weren't already after a hip fracture. So that's, and half of those people will still be in a nursing home 1 year later. So that is, you can see falls are a significant cause of disability for older adults. So if alcohol is one thing that we can control to reduce fall risk, I think that's very worthwhile. On the next slide, again, heavy drinkers are more likely to fall, and it does seem to be dose dependent. So even reduction might help with reducing risk of falls. And next slide. Again, falls are usually multifactorial. So we look at alcohol, but we look at other things too. I'm going to skip the next 2 slides and let's go back to the slide with Louis. Or Louis, don't know why I keep calling him Louis. But he is our fellow who is 78, retired salesman, did a lot of drinking as part of his job, and that routine has persisted since he quit work. Do we want to tell Louis to quit drinking? And what advice would we give him? And is Louis somebody who I would consider working with some of my colleagues in substance use and addictions to see if we could help him to reduce his alcohol intake or even stop his alcohol use? So we can consider that and talk about it a little bit more as the other presenters share their information. But, I would definitely talk about alcohol use with Louis I would share information with him about his risk. So he would be considered drinking heavily, and that will increase his risk of falling again. So I think that's information that Louis needs when he thinks about his alcohol use. So that's pretty much what I wanted to share today. I'm really looking forward to hearing our other presenters share their information, because I think that that's going to be very valuable in terms of putting some of the info that I've shared into some practical terms. So thanks for your attention, and I will stay with the group for when we have a Q&A.
Thank you, Nicole. Excellent. Really appreciate that very much. We're going to go right to Julie Kirchhoff and Gina Phillips. They have a brief presentation for you, and you won't get the slides from their presentation, but they have 3 super handouts, which will come to you. Take it away, ladies.
Great. Thank you, Robin and Dr. Didyk. You are a tough act to follow, so we will do our best here. So I'm going to just share my slides, and Pete, if you can make sure that that is seen by everybody, just give me an okay. Awesome.
It's good too.
Good, thank you. And then Gina, I just got a text from Gina that she might have lost her connection. Gina, are you with me, or am I solo here? All right, I might be on my own here, folks, and that's more than okay. But Gina, if you do show up, know that I'm happy to have you chime in when you can. So my name is Julie Kirchhoff, and I think everyone maybe saw my introduction slide at the beginning of even Robin welcoming us here today. And I certainly work in the community and have been in the community for several years now, and focus on substance use in the older adult. And today I'm just going to present a few slides that were from the Canadian Centre on Substance Use and Addiction, specific to the new health guidance that was articulated to us earlier this year, which may have come as a bit of a shock to many of us. So it's Canada's guidance on alcohol and health, and they were, I think, released in January of this year. So it's very, very hot off the press. And the timeliness of this update. So maybe just to give a bit of context, many years ago, I think it was back in 2011, the Canadian Centre on Substance Use and Addiction released what they called low-risk drinking guidelines, and that was for the general population. And those guidelines were certainly intended for us to be aware and to certainly work towards if we could. And then there was another coalition that came together even before that time frame of those low-risk guidelines coming through, and that was called the Canadian Coalition for Seniors' Mental Health. And this was a team of pretty significant health professionals across our country that came together in the early 2000s to look at what can they do as a mandate to help put out some information to the older adult population, especially in the realm of good mental health. And then they looked at those low-risk drinking guidelines that were released in 2011. And finally, in 2020, adapted those guidelines to the older adult. And then, so they released those guidelines, which I'll share with you. Actually, I think it's in one of those infographics that Robin will distribute to everybody. And then today's talk is really on the Canadian Centre on Substance Use and Addiction coming back with what they had released in 2011, with saying, look, there have been significant developments in our evidence-based knowledge about alcohol-related death and diseases. There is evolving research on alcohol and its social harms. And other countries have actually updated their guidelines, which were significantly different than the ones that had been released in 2011, and even different than the ones that were released by the Canadian Coalition for the Seniors' Mental Health in 2020. So really and truly, at the end of the day, this recommendation from the Canadian Centre on Substance Use and Addiction is really about us as individuals across all age groups to consider reducing our alcohol use. So to reduce the risk of harm from alcohol, it is recommended that people living in Canada truly consider reducing their alcohol use. So let's unpack that a little bit more if we can. And I know Dr. Didyk had put a slide up that looked similar to this as well. And this is helping us understand what even does one drink actually look like. And this actually has a definition to it. So when we as individuals say, oh, I just have one drink of wine at supper, do you actually measure that? And likely not, right? So it's recognizing that there is a quantity that indicates if it is a standard drink or not. So for example, a standard drink of beer is the regular size cans of beer. So it's a 12-ounce can of beer. That's about that 5% alcohol percentage. That is considered one standard drink. A cooler, the same idea. If it's a 5% alcohol cooler, then it's a 12-ounce can or beverage. For wine, it's 5 ounces. And for alcohol or hard liquor, rather, it is 1.5 ounces. So kind of gauging that, that could even be a starting point as you are thinking about your alcohol use or your alcohol intake. It might be about this as a starting point. Well, what am I actually even measuring my drinks? And maybe that could be where you start to reconsider with this new knowledge. And then the Canadian Centre on Substance Use and Addiction put out this continuum of risk. And I think Nicole also shared a slide that looked like this as well. And at the end of the day, the 0 drinks per week, of course, equals no risk. And it certainly added up that 1 to 2 standard drinks in their research, you will likely avoid alcohol-related consequences for both yourself and others. Okay, so that is considered low risk. So it's 1 to 2 standard drinks per week, which might be a whole lot different than what you might be consuming right now. So it's thinking that one through. A moderate risk, so even going up to 3 to 6 standard drinks per week, then elevates our risk to a moderate level. So your risk of developing several different types of cancer, including breast and colon cancer, all increase. And then when we get to the point where we're at 7 standard drinks per week, your risk of heart disease and stroke increases. And any additional drink radically increases the risk of these alcohol-related consequences. So keeping all of that in mind as you make your own decisions around your choices in consuming alcohol. And then the center also articulated the occasion of drinking and how many drinks is on that low risk scale as well. So at a certain occasion or event where you are consuming alcohol, they are encouraging consuming more than, or highlighting rather, that consuming more than 2 drinks in one occasion is associated with increased harms, risk of harms, including to yourself and others, including injuries and violence as well. When 0 is the limit. So in some circumstances, not drinking alcohol is in fact the safest. And these might seem pretty obvious to us as well, but it's, driving a motorized vehicle, using machinery and tools, taking medicines or other drugs that interact with alcohol, such as what Dr. Didyk had articulated quite well, and doing anything that requires lots of physical activity or even dangerous physical activity, being responsible for the safety of others, and then having to make important decisions. You might want to avoid that alcohol in those times of your life. And when we look at reproductive health, and that might not necessarily apply to the older adult population here, but we might know someone in our lives that is. So when pregnant or trying to get pregnant, there is no known safe amount of alcohol use. And when breastfeeding, not drinking alcohol is safest. In the context of sex and gender, at 7 or more standard drinks of alcohol a week, the health risks increase more steeply for females than for males. And far more injuries, violence, and deaths result from men's alcohol use, especially in the case of per occasion drinking. So key points to keep in mind. And alcohol in our youth. Drinking is actually the leading cause of death and social issues in young people. And intoxication is associated with high risk for injuries, aggression and violence, dating violence, and worsening academic performance. And youth under the legal drinking age should delay drinking for as long as possible. And I see Gina here just in time. Perfect. So I'll let you take it away, Gina, and I'll mute myself and just forward the slides as you need it.
Great, thank you. I'm so sorry for that, everybody. It just kind of disappeared. But following what Dr. Didyk and Julie have mentioned, sort of the key messages, and hopefully what we can all do is have some reflective practice around our consumption and our intake in regards to alcohol. What is our relationship like with alcohol, regardless of our age and on that spectrum? Ideally, what this guidance was hoping to do is just to give the overall philosophy that less drinking means less risk of harm from alcohol. It was also thought that people in Canada, so Canadians, have the right to know that drinking alcohol is associated with elevated risks. It's not been really talked about in that manner or as forwardly, perhaps, as this new guidance. The guidance can help make us and give us the opportunity to have more informed choices about alcohol and our consumption, and like I said, our relationship to alcohol. So with alcohol, our risks do escalate in terms of the outcomes of potentially, having cancer. Oh, sorry, go back. Cardiovascular issues, injuries, violence, and on-road vehicle crashes, unfortunately. Next slide, thank you. Now, this new guidance may have potential policy implications. A lot is unknown at this time, but let's say it's brought up at more healthcare tables and on different political tables. Supportive alcohol policies could look like mandatory labeling on alcohol containers. And what that means is sort of standard drink labeling, guidance on alcohol, and health labeling overall, and potentially health warnings. So similar to that of what we've seen in the tobacco industry. We've not seen this in the alcohol industry so far. There could be strengthened restrictions on alcohol availability. We've seen an expansion beyond the LCBO now. It's more readily available, more widely available in different settings. There could be increased prices, and then strengthened restrictions on alcohol advertising. So the alcohol industry has done a beautiful job of glamorizing alcohol use and intake and consumption, whether that's through print, advertisements, and television. So essentially, consumers, those of us that are purchasing alcohol, need to have consistent, easy to use information on alcohol containers and packaging. Next slide, please. So if we are going to take anything away from today, hopefully we can just think about, what is my intake like? And if I'm curious and wanting to reduce my harm and my risk, these are some potential strategies, one or more, that you could consider. So keep track of how many drinks you're having per week. Maybe you're drinking more on some week than others, and you want to look at it over the course of an entire month. And just think about, why might I be drinking more or less? And if I want to reduce, what does that look like? Or what could it look like in order for me to do that safely? Stick to the limits that you've set for yourself. And that could be on an event basis, like when you're going out for a particular occasion. That could be on a daily basis or a weekly basis. You can break it down in terms of different settings and timeframes. Drink slowly, so pace yourself. Drink lots of water, which hopefully we're doing anyways, regardless of our alcohol consumption, but especially when we are consuming alcohol, be mindful of your fluid intake and consume more water. For every alcoholic drink, consider having one non-alcoholic drink, which might not be your practice right now, but it is a good strategy. Choose alcohol-free or lower alcohol content beverages. And now that industry is booming. The alcohol-free options for wine, beer, and spirits are way more palatable, more flavorful, more enjoyable now compared to before. And they're doing a really good job at distilling alcohol-free options for people that you can really enjoy and not feel like you're missing out on anything. Please eat before and while you're drinking, so don't consume or continue to consume on an empty stomach. And then also try to build in the idea of having alcohol-free weeks or days, and building up from there. And consider doing alcohol-free activities, or as a host, how might you include that into your event or your activity? And I think that summarizes our portion. Thank you so much.
Hello. Oh, how interesting. I'm getting feedback over my Wi-Fi system here. Folks, thank you very much, Gina and Julie, for that. I'm going to now introduce Janetta, and she's one of the excellent social workers that we have at the Society. And Janetta is going to take 5 minutes and give us a quick review of some of the services that you can access. Thanks, Janetta.
Thanks, Robin. So some of the people on the call may be familiar with the programs and services offered at the Alzheimer's Society, but for some folks, this may be your first introduction. So I wanted to take some time to share a bit about what we offer here at the Society and what one can expect when they connect with us. So the Alzheimer's Society offers a variety of programs and services to support persons living with dementia, their family members, and friends. These programs include special education topics like this one, varying support groups for care partners, a variety of social and recreational opportunities for people living with dementia, and a Minds in Motion program, which is an exercise and social program designed for persons living with dementia and their care partners to attend together. We offer most of these programs with the option of attending either in person or online. And our in-person support groups offer respite opportunities if finding care for the person you're supporting is a barrier to participation. The Alzheimer's Society can also play an instrumental role in helping people to navigate access to other community resources through our First Link program. It's important to note that even though we are called the Alzheimer's Society, we do offer support and education regarding any type of dementia and provide support throughout the journey. So from initial concerns about memory loss to diagnosis, from living in the community to long-term care, and from early stage to late stage dementia. All of our programs are offered at no charge, thanks to generous donations from community members such as yourselves. So how might someone become involved with the Society and participate in some of these programs and supports? We encourage people to self-refer for education and support by calling into our office. When folks call in, one of our staff members would open a client file and book a short conversation over the phone with one of our social workers, where we might ask some questions about concerns, challenges, and changes. And based on that information, we can then better make recommendations to some of the education or social programs, or might make some referrals or links to other community organizations. If there's any clinicians and healthcare professionals on the call, you can find our referral form online on our website, and completed referral forms can be sent to our office via fax, and the fax number is on the referral form, or a referral can sometimes be made through CareDove. So that's all for me.
That's awesome, Gina. Thank you so much. I know we're running a titch behind time, but I think that it's really important that we just spend a moment or two on the next part. We had somebody who, unfortunately, her name is Barb, was unable to be with us today. So Julie is just going to take a moment and speak to Barb's story, because it is the personal experience that really ties the information that we've given you to reality. So I'm going to bow out and just give you a couple of minutes, and then we'll go to the Q&A. Okay, Julie?
Thanks, Robin. So Robin, did you say you were going to share that 2-minute video clip as well? Or
yeah, Pete's got that ready for you. When you're ready,
okay.
He's ready.
Excellent. Okay, thanks, Pete. So I've known Barbara for several years now, and she actually sits on the working group that Gina and I both connect with every month. And Barbara's been a part of that group for a couple of years now, and she represents someone with lived experience with an alcohol use disorder. I just want to highlight that everyone's relationship with alcohol is very different. We come to the plate as an individual, and we have that relationship with substances in our own way, either with no contact with alcohol whatsoever, to the other end of the spectrum of becoming dependent on it. And certainly Barbara is full disclosure. She does have an alcohol use disorder and has struggled with that for many, many years. And this video clip is a part of her journey in trying to find sobriety. And she shares in this clip how she struggled with that and how she needed to look beyond herself and beyond her family And she also was able to sit back and recognize the struggles that her family also had in this journey. But it's highlighting that sobriety is not a destination point. It is a journey. And I know Barbara very much wanted to be here today, but is struggling in her relapse right now with her substance. And but was bravely wanting me to share that bit of information and to also highlight this part of her journey that, and this video was done in 2021. And take it away, Pete. Thank you.
And this continued, I would say, for until just a couple of years ago, that I would go into rehab, I would dry out, I would say stay dry for some months, and then something would happen and I would lose control and I would start drinking again. And one thing I should say in telling my story is that my family, my son, my parents, my husband, were like rocks for me. They took me back to rehab. They tried to help me. And I think one of the reasons I mention this is that your immediate family can't help you. They don't know enough about alcoholism. They don't understand it. They can't understand why an outwardly normal, happy person needs this additional prop in their lives. It just isn't something that's understandable by an ordinary person. So I come to sort of the bright ending to my story. I moved to the Guelph area and I was put in touch with a social worker. And she was able to see a future for me that I no longer believed in for myself. And she was able to point me in the direction of various tools and supports, in particular, a personal counselor who was a good fit for me. And gradually, over a period of some months into a year, created a program that was almost purpose-built for me as an individual. And that has allowed me to become relaxed and to stay away from alcohol and to navigate my way through my husband's passing, which was a very traumatic event, without going back to drinking.
So that was a tiny clip from Barbara's story, which is actually available to be shared. And we will be sending out the article and the link when we send out the other information and the evaluation today. It's, I believe, a 20-minute film, Julie. Am I remembering that correctly?
27.
27.
Yeah.
I knew there was a 27 minute film. And you might find it of interest. That was just a clip. Did you have some closing remarks for that before we go to the Q&A, Julie?
I think maybe just the key pieces are that everyone's relationship is very individualized, and everyone's approach, if there is an alcohol use disorder on board that needs to be addressed, that does need to be tailored to that individual. And I think going to the dementia saying, where you've met one person with dementia, you've met one person with dementia, the same goes through with addiction. When you've met one person with addiction, you've met one person with addiction. So it's recognizing that unique combination to help find their journey through to hope.
Great. Thank you very much.
Thanks, Robin.
Well, now's the time that we are going to ask all our panelists to please turn their cameras back on. If you have questions for our panelists, I would appreciate you typing them into the chat, and we'll share them. I do know that I had a question already come in, and it had to do with somebody who is living with dementia who wants to be consuming drinks on a regular basis, and the partner is looking for interventions. So now, Julie, no, it was Gina, you were mentioning those great new products they have with no alcohol, but they taste good. So y'all are muted now. If you care to unmute, and then anybody can sort of speak to that issue. Dr. Didyk, I'm wondering if just even thinking about alcohol and dementia, you could just start the discussion off.
Sure. Is everyone able to hear me? Okay. So yes, thanks very much, Robin. And that does come up. And again, in my practice as a geriatrician, if I'm seeing a person who's living with dementia, and we always ask about alcohol use, and if the person is drinking alcohol, then that's something that we'll talk about. And if we look at sort of those acute and chronic changes that can happen in the aging brain, it's amplified in the aging brain with dementia. So anywhere that a person is along that cognitive spectrum, alcohol use has the potential to worsen the symptoms of cognitive impairment, and can also exacerbate if there are responsive behaviors in dementia that can sometimes be worsened by alcohol use. But then also considering the symptoms of dementia, it's sometimes a challenge to have the person or to help the person to reduce alcohol use. So I know that oftentimes a lot of the strategies that I would talk about would be with the care partner, because it may be that the care partner needs to modify or moderate access to alcohol, or the actual substance that the person is using when they are going for alcohol. So it might be a matter of replacing an alcoholic beverage with something that has less alcohol content. It might involve helping the person to defer drinking alcohol, participating in another activity. Sometimes, and this can be controversial, sometimes using fiblets or therapeutic lies, right, is what they are. Some people aren't comfortable with that, but sometimes it can be used to, help a person cut down. So to say that, somebody has already had a drink, or, oh, we're going to do that later, or remember you said, today's the day we're going to try near beer. Those strategies can help, but usually the care partner has to be a very strong partner in making that reduction happen. It's going to be, as Julie and Gina mentioned, especially Julie, I think, said that it's going to be different for everybody. So the same strategy won't work for everyone, but generally just trying to reduce that access or the amount is the way to go.
Thank you. Thank you very much. Now, this is very much a medical question. If you could please comment on alcohol and the ongoing use of levodopa for Parkinson's.
Well, levodopa levodopa is a way of getting dopamine. It's a therapy for Parkinson's disease and some other related disorders that are related to Parkinson's. And alcohol, unfortunately, can exacerbate some of the side effects of dopamine, which can include a drop in blood pressure when somebody changes position, or what we call postural hypotension. So not everyone who's living with Parkinson's and is taking L-DOPA experiences postural hypotension, but if they are, then taking alcohol is going to worsen that. So, and if we think about alcohol use, and fall risk, and Parkinson's disease also being a fall risk for many, then I think I would be very cautious with alcohol use. And I think really thinking seriously about the low risk guidelines or no risk guidelines would be advisable.
Thank
So
you.
if you have to keep taking L-DOPA for your Parkinson's, then cut out the alcohol.
That's pretty clear. Thank you. That's good and straightforward. I'm going to sneak one more question in. I am one eye on the clock, but one eye on the chat, and I think it's really important. I'm just wondering, you made some good suggestions what a partner can do to help reduce alcohol intake. But if people living with dementia are drinking regularly and they might not realize how much they're drinking, perhaps the partner is trying some of the techniques already that you've suggested, but needs some more support. Where are the best places to go to get further support, particular ideas? Maybe Julie and Gina, you might be the folks to answer that one.
Sorry, I had to unmute.
Yeah.
So there's a few. So it certainly is recognizing that the short-term memory losses will play a role in what the person with dementia is believing that they're consuming as well, right? But looking at resources that are supportive, you'd start off with, what are you looking for specifically? So Here 24/7 is a crisis line that is available here 24/7. So that could be a gate to actually start the conversation to link with some resources. So that's something that's in the immediate. If you're looking at something that could be maybe accessed within a day or within the week, then you're looking at things like Al-Anon to maybe help give you some guidance. But that can be maybe tough to get to. So then it's looking at resources like House of Friendship or Stonehenge or CADS, which is through Homewood. So those are all three organizations that are within the Waterloo-Wellington region. Yeah.
Just want to say CADS, just for the folks who wouldn't know the acronym.
Community, I think it's Community Addiction Services.
Isn't it Drugs and Alcohol Services?
Yeah. And that's direct counselors. But Here 24/7 would link you to any of those three organizations as well.
Great.
And then when it comes to the specialized geriatrics piece, which is myself, it's a little bit further down the line if you needed my services to step in, or even Gina's services through the SGS team. And that would be through your family doctor or through someone at the Alzheimer's Society or a care coordinator, or even Dr. Didyk.
This is the so just also want to address very briefly, and I understand people might need to go because it is after 1, but the issue of old habits die hard. People who have had a routine, have developed dementia, and are still living within their past routine, and therefore have always had alcohol in the house, have always had X number of drinks a day. They might not have insight into their disability. They might have some anosognosia. They don't recognize that they have a dementia or a disability. And these are challenging questions. I don't think you're going to answer them in the next 30 seconds.
If I can highlight one point to that, though, maybe, Robin,
sure.
is in those habits, and sometimes what happens too is the alcohol intake can even increase because they didn't remember they already poured and consumed a drink earlier. So before you know it, they're actually consuming more and more and more. And the concern there is also around the withdrawal. If we just yank everything away and stop their access points, if it's access to their money or access to their substance or however we're creating those barriers, if we do it abruptly, we can actually send them into an alcohol withdrawal, which I believe Dr. Didyk had even mentioned in her presentation, the withdrawal seizures that could even happen as well. So it's certainly having to do it in a creative way, but very mindfully. And when we look at community home tapers, tapering from alcohol, it's reducing by 1 standard drink per day every 2 weeks. So it's really slow. But if you're ever concerned about where to start, how to begin, it's really getting in touch with your health professionals to help start that conversation so that you are informed as a caregiver if you're taking the lead on helping your loved one, the person with dementia, reduce their alcohol intake so that it's done slowly and effectively and replaced appropriately as well.
Thank you. That is a hugely important point, and I think that's where we're going to have to end just because of the timing today. I want to sincerely thank everybody who participated, who gave us information. Take good care of yourselves. If you need the services of the Alzheimer's Society, we are a phone call or an email away. Safe travels to you all. Thank you very much. Bye now.